Hey, good evening, everybody. It's great to have you with us, and it's a great webinar on hypertension management, making the right choice from the start. And I'm very glad to be moderating this session with my dear friend, Professor Hussam Andil. And we have two distinguished speakers tonight on the subject, Dr. Martin Strauss, from assistant professor from Toronto, and Dr. Krzysztof Narkiewicz, I hope I pronounced it right, from Netax University. And we are very glad to have them here. And unfortunately, it's a live webinar, not they are personally here in Cairo. We would like to welcome maybe next year in Cairo. I would like to thank Servier Company for sponsoring this event. And of course, we all know that ACE and ARBs have been well established in the management of hypertension, yet the evidence regarding reducing mortality and myocardial infarction is still debatable with ARBs, and I hope Dr. Martin Strauss will shed some light on this, and we will have the discussions after each talk, and I hope we'll have fruitful discussion. Please put your questions, and we will answer them after the end of the talk. Professor Martin.
Great. Thank you very much. It's really a pleasure to virtually be in Egypt today, and I'd like to thank Servier very much for inviting me today. These are my disclosures, and we're going to be talking about the differences between ACE inhibitors and ARBs. Well, the starting point is, what is the impact of what we do every day in treating people with high blood pressure? And this is a meta-regression analysis of over 600,000 patients, over 100 clinical trials. And as you can see, along the x-axis is how much systolic blood pressure falls, on Y, major adverse cardiovascular events. And the more you reduce blood pressure, the greater the benefit. So we're doing good for our patients. But what's intriguing is what is the impact specifically on reducing blood pressure? For every 10 millimeters you reduce of systolic blood pressure, stroke falls by 27%, coronary heart disease, which is MI and death, by 17%, mortality is 13%. And this is the key. The biggest bang for your buck on blood pressure is always for stroke reduction. Well, the majority of people with hypertension have an activated renin-angiotensin system. So worldwide, many people will start either an ACE inhibitor or an ARB. And as we know, most people require 2 or 3 different medications. And the drugs of choice are long-acting dihydropyridine calcium channel blockers or long-acting thiazide-like diuretics such as indapamide. And you're going to be hearing more about the combination of pills, which is sort of really the gold standard of initiating in the majority of people with hypertension. Well, we're faced with a very unique set of circumstances with the coronavirus. And as you know, the coronavirus binds to the cell by the ACE2 receptor. And the main concern was, and we learned this initially when SARS came out in 2004, that this virus binds to the receptor. And the question is, could ACE inhibitors or ARBs upregulate it and increase your risk of developing COVID? And there is a multitude of studies now which suggest that isn't the case. No increase in the risk of coronavirus. What I do want you to be aware of is that within the cell, when you do get corona, ACEs and ARBs have different effects. And in a recent article in the New England Journal of Medicine from Reynolds et al. From New York, they took a look at once you had severe illness from COVID, which means ICU admission, ventilator, or death, what the impact of ACEs and ARBs were. And as you can see, if you were on an ACE inhibitor when you were admitted, there was a 3-fold less incidence of severe disease compared to an ARB. Unfortunately, they didn't specifically break it down into mortality, but ACEs had the lowest risk of all antihypertensive agents. Definitely intriguing and food for thought. Well, as cardiologists, we all learned about ACE inhibitors 30 or 40 years ago, trials like the SAVE, SOLVE, Consensus. You would have people with systolic dysfunction of the left ventricle, blood pressures 100 to 110 millimeters of mercury. You put them on an ACE inhibitor, didn't really affect the blood pressure, but they felt better and a dramatic reduction in mortality, and ACE inhibitors quickly became the staple in congestive heart failure. We then went on to explore people without heart failure, with vascular disease or diabetes, in studies such as the Europa, perindopril versus placebo, HOPE, ramipril versus placebo, and the starting blood pressure in these trials were 137 to 139 millimeters of mercury. Remember, those were the targets of treating hypertension, and both of those studies showed dramatic reduction of major adverse cardiovascular events with very small reduction in blood pressure by about 3 by 1.5 millimeters of mercury. Well, we're all familiar with the renin-angiotensin system cascade, and ACEs, as you know, decrease the production of angiotensin II, and ARBs specifically block the AT1 receptor. And the question comes out, do ARBs provide the exact same cardiovascular protection as an ACE inhibitor? Well, in 2004, I was invited by the British Medical Journal to write an editorial on ARBs, which was published. And in this editorial, we said the following: ARBs were well-tolerated antihypertensive agents. They were effective at lowering blood pressure, but unfortunately, in not one trial did they reduce the risk of myocardial infarction or death, despite ACE inhibitors having those sorts of benefit in those trials. We went on in this article to say there was biologic plausibility of why ACEs and ARBs are different. ACEs, as you know, suppress angiotensin II. Angiotensin II not only raises your blood pressure, but has direct toxic effect on tissues. But that's only half of the equation. The other half of the equation is ACEs prevent the breakdown of bradykinin. Bradykinin is that molecule that causes cough with ACE inhibitors in 2 to 5% of people. And via nitric oxide, bradykinin improves endothelial function, causes fibrinolysis, it potentiates it, release of TPA, and what's called ischemic preconditioning, the ability to withstand recurrent ischemia. Well, how about ARBs? What is their mechanism of action? Well, there's no cough with ARBs, correct? And the reason is they do not upregulate bradykinin, that life-saving molecule, so at least theoretically wouldn't have the same cardiovascular protective effect of an ACE inhibitor. ARBs, however, block the AT1 receptor, which is a good thing because AT1 mediates many of the bad effects of angiotensin II. Unfortunately, we learned early on that blockade of the AT1 receptor inhibits a negative feedback loop, and the levels of angiotensin II increase 200 to 300%, and they stay up that way persistently. Remember, angiotensin II is a very toxic molecule. Well, it was argued that's okay. Hyperstimulates AT2, which causes vasodilation, which is a good thing. But we also know AT2 in coronary arteries leads to plaque rupture, myocardial infarction, and death. So when our editorial was published in December 2004, needless to say, it was very controversial. Well, 6 months later, in Milan at the European Society of Hypertension, the blood pressure lowering treatment trialist collaboration from the George Institute for Global Health decided they were going to address the question of ACEs and ARBs. And at that time, there were approximately 140,000 patients in randomized trials, and they did a meta-regression analysis. On the x-axis is how much blood pressure fell in each trial. On the y-axis, the different clinical endpoints, and we'll first look at stroke. In the green line, you have ACEs. More you lower blood pressure, more you reduce stroke. ARBs, the exact same. And as you can see, if there's no blood pressure reduction, no impact on stroke. Somewhat intuitive. How about for the endpoint of congestive heart failure? Again, ACEs and ARBs were the same, and no blood pressure independent effect. In our editorial, though, we wrote about myocardial infarction and death. And as you can see by the blue line here, even if an ACE inhibitor didn't lower blood pressure, there was a statistically difference of 9% reduction in the risk of MI and death, even if blood pressure wasn't reduced. What about ARBs? ARBs actually had a trend for harm, which was 8%. What was significant was this difference, 17%, P equals 0.002. Put another way, in 2005, randomized controlled trials in almost 150,000 patients in an analysis by one of the most elite research group in the world showed for whatever an ARB lowers blood pressure, if an ACE lowers it the exact same, an additional 17% risk reduction in MI and death. And as I tell my cardiology fellows, if I showed you this slide in 2005, I don't think there would be much discussion to say which drug you would end up preferring. In 2006, I was approached by the American Heart Association to do a parallel meta-analysis along with my good friend and colleague, Alistair Hall, in circulation, and looking at ACEs versus ARBs. And at that time, 39 trials of ACE versus all comparators, 150,000 patients. ARBs, 11 trials, 55,000. And for the endpoint of stroke, you can see ACEs and ARBs are about the same, approximately 7%. And what that tells us is, in these parallel meta-analysis, blood pressure reduction was probably the exact same. But we were interested in global death, CV death, and MI. And what you can see, ACEs reduced it 9 to 14%. Look at these p-values, 0.00001. So there is no question the life-saving property of an ACE inhibitor appears to be above blood pressure lowering. Otherwise, the risk of stroke would have been reduced more than the risk of MI and death. Well, how did ARBs do? Unfortunately, no impact on global death or CV death, and the risk of MI actually went up 8%. Well, one of the things that people would argue, and reasonably so, well, the studies were done in different times and different patient populations. But in actual fact, the comparator arms in the ARB and the ACE trials had the exact same event rates, which says relative homogeneity within the patient population. Well, how about in hypertension? What do we know in hypertension trials? And this is the biggest meta-analysis of hypertension trials done by Professor Kim Fox, looked at 160,000 patients with hypertension. And these were trials all from the year 2000, which suggests similar comorbidities and medications across these trials. And they looked at the single most important endpoint, which is dead bodies. The first thing they looked at is ACEs and ARBs together, because it's very common, for example, especially among nephrologists, they don't talk about ACEs and ARBs, they talk about them as a group, RAS inhibitors. 20 trials and all-cause mortality, if we look down here, 5% risk reduction in all-cause mortality, P equals 0.032. And if I just showed you this slide, most of you would agree ACE or ARB, they work great in hypertension. But Dr. Fox next went on and just looked at the ACE inhibitor trials. And if we just look at the ACE inhibitor trials, there is a 10% risk reduction in all-cause mortality, P equals 0.004. And it was interesting because this was driven by the results of 3 trials. Ascot trial, which you're familiar with, perindopril amlodipine versus a beta blocker and a diuretic. The advanced trial, which we're going to be talking about shortly, and the HIVET trial in elderly with perindopril indapamide. Now, whether the robust effect is because perindopril is a very long-acting drug, has high tissue affinity, and significantly impacts bradykinin, we don't know for sure. Well, how did ARBs do? And look at some of the names of these trials you're all familiar with. Renow, IDNT, Life, Scope, Moses, JICI, Profess, Transcend. Unfortunately, compared to other comparators, ARBs in hypertension trials did not reduce mortality one bit. So all of the benefit when you combine ACEs and ARBs together is driven by the ACE inhibitor trials. Another meta-analysis that you should be aware of is the Cochrane group published in 2014. And I think most of us would agree that the Cochrane database of systematic reviews is truly outstanding. What was their conclusion? And they said, well, ARBs are slightly better tolerated than ACE inhibitors. There is a higher quality of data supporting the use of ACE inhibitors to prevent death, strokes, and heart disease that must be considered before choosing ARBs over ACE inhibitors. Now, I want to share a third meta-analysis with you in hypertension because that was published in 2019 by Demu's group. And in this one here, they said ACEs and ARBs are really no different. But what I want you to understand is this was 8 trials of 25,000 patients, and these weren't any new trials. So just because somebody comes up with a new meta-analysis doesn't mean that it overrides the previous data of extremely well done ones over here. Well, when we talk about clinical trials, the gold standard, of course, is a double-blind, randomized, controlled trial. But when you talk about absolute drug efficacy and safety, it can only be assessed when the comparator is a placebo. So Dr. Hall and I went ahead and we took a look at any research group that did parallel meta-analysis of ARB versus placebo trials, ACE inhibitor versus placebo trials, and we found 4 different groups that looked at this data. We actually published it a few years ago as a letter to the editor in the New England Journal of Medicine. So let's look at first at ACE versus placebo. First of all, I want you to be aware that this parallel meta-analysis is from Thermopolis and Dr. Alberto Zanchetti, who is the father of hypertension in the world, Savarese, an Italian group, Bangalore, and Franz Messerly, who's considered the father of meta-analysis, and a group from China. Well, how did ACE inhibitors do versus placebo? Look at that, up to 60,000 patients in placebo-controlled trials. Hazard ratios fell 0.89 to 0.91, all of them statistically significant. Put in different terms, ACE versus placebo reduces the risk of death 9 to 11%, P less than 0.05. So when I show this to the cardiology fellow, they smirk and they say, well, what do you expect? It's a placebo-controlled trial and ACEs lowered blood pressure. Of course, it would reduce the dead body count. Well, before I show you the ARB data, I want you to realize in the comparator arms, the placebos, mortality rate were about the same, approximately 8%. ARB versus placebo, look at that, 66,000 patients. There are more patients in ARB versus placebo trials than there are ACE inhibitors. And how did ARBs do versus placebo? Hazard ratio 1.01 to 1.03, meaning as compared to a placebo, and despite lowering blood pressure, ARBs did not prevent a single death. Well, there was a lot of interesting discussion, and we were invited by the American Heart Association again, and we wrote a more extensive analysis on ACE and ARBs in circulation. Well, any discussion nowadays must include a talk about diabetes because I'm sure it's epidemic in Egypt like it's epidemic in Europe and North America. One of the most intriguing trials is a placebo-controlled trial called the ADVANCE trial. And it looked at over 11,000 diabetics with one additional risk factor, compared placebo to perindopril and indapamide, and look at the starting blood pressure. It was 140 millimeters of mercury. When this study was done, that was the target blood pressure. So according to that Times, you wouldn't need treatment. So those who got perindopril and indapamide dropped blood pressure 5.5 by 2 millimeters of mercury. And as you can see, the dead body count fell dramatically, 14%, P equals 0.025. Well, what is the biggest ARB versus placebo trial in diabetics? That was published in the New England Journal of Medicine, called the Roadmap Trial. Over 4,000 patients, similar starting blood pressure, 139 millimeters of mercury, dropped blood pressure about 3 millimeters of mercury, sort of like Europa and Hope. And what they wanted to see is whether they could prevent end-stage renal disease in diabetics that had no microalbuminuria. And of course they couldn't because the people were too healthy. But they did prevent microalbuminuria, making it very reasonable that, hey, diabetics, blood pressure 139, I can lower it with the olmesartan, prevents microalbuminuria, we should use it. Well, as everybody knows, the data safety and monitoring in every trial looks at important endpoints like dead bodies. And as you can see, the composite of death from cardiovascular causes, 15 patients in one arm, 3 in another, 5-fold different with a p-value of 0.01. And if I showed you this data, you would say, that is very impressive, and we should be routinely using olmesartan in these patients. Unfortunately, it was olmesartan that was associated with the 15 deaths, and the placebo that was only associated with 3. And this, to me, was a very worrisome finding, but really has sort of gone under the radar for most people. Well, what are some of the guidelines we have now in diabetes? The NICE guidelines in the UK, ACEs are first line in diabetics, ARBs only used with ACE intolerance, and the exception to this is African or Caribbean family. And the reason is low renin system, so not as effective blood pressure lowering. But what they go on to say, the first line antihypertensive treatment for a person of African or Caribbean family origin should be an ACE inhibitor plus either a diuretic or a calcium channel blocker. That's the way to go. The other interesting guidelines is in the United States. Their new guidelines in hypertension is if you have chronic kidney disease with microalbuminuria, and probably 80% in the US is from diabetes, ACE inhibitor is number 1. ARBs is only if you are ACE intolerant. Now, one of the questions that comes up, which is very reasonable, is why don't you discuss the head-to-head data of ACEs and ARBs? Unfortunately, there's a little bit of paucity of the data, but let me share with you the biggest trial ever done head-to-head, and that was, as you know, the OnTarget trial. 8,000 people telmisartan, 8,000 people ramipril, high-risk patients with vascular disease or diabetes, and starting blood pressures were about 140 millimeters of mercury. What was the conclusion published in the abstract? It said telmisartan was equivalent to ramipril. That seems like a game, set, match. Unfortunately, this trial was not a trial of equivalence. An equivalence trial would have taken about 4 times more patients. What this trial was for something called statistical non-inferiority, and this is in the published paper. Now, the word non-inferior, when we interpret it literally, means equivalent, alternative, or interchangeable. The concept of statistical non-inferiority does not mean that. A little bit confusing, but I'm going to show you what Dr. Youssef wrote in that paper. And he said what it proves is telmisartan retained at least half of the effect of ramipril. Even if the event rates were the same, all it could show was that it's at best at least 50% effective, and the confidence intervals at 97.5% just means that that is what's proven. Now, how can I prove to you quickly and easily that telmisartan wasn't proven equivalent? I'll tell you what the FDA wrote. The FDA, after the study was published, did not give telmisartan a first-line indication or a second-line indication. It wasn't until Dr. Youssef and Mark Pfeffer went to the cardiorenal board and fought with them that they got the second-line indication in the US for ACE intolerance. How about in Canada? The exact same as US. And what about the European Medicine Agency? In their full report, they said there is no evidence that telmisartan was better than a placebo at reducing mortality. That being said, telmisartan still got a first-line indication in Europe, and really difficult to understand why. So a general concept of statistics is the apparent absence of a difference does not mean a true difference does not exist. So whenever you have clinical trials, you always have meta-analysis. I'm going to share with you the biggest meta-analysis ever done of head-to-head trials of ACE versus ARB, which was actually done by Professor Messerly's group and published in the Mayo Clinic Proceedings. And what his conclusion was, in the head-to-head comparison trials compared with ACEs, ARBs had a similar risk for all outcomes, including all-cause mortality, CV death, and MI. Well, let me show you the exact points in this meta-analysis. First of all, 8 trials, 22,000 people. Remember I showed you Kim Fox's meta-analysis? We were talking about 160,000. In the placebo-controlled trials, we're talking about 60,000. This is 8 trials, 22,000 people. And as you can see, the majority of the patients in blue were from on target, 17,000. And the remainder, a big bulk, was from a trial called the CORE trial. I'd never heard of that before. It was a European trial, 1-year data, very, very low risk patients. But then they went on and they took a look at the most important thing, which is mortality and dead bodies. And as you can see, in this 22,000 patients, 2,000 people died, almost 10%. That is high-risk population. But when we take a look in blue here, 98.5% of all of the deaths in this meta-analysis were from the on-target. So if you want to understand about head-to-head trials, it isn't this meta-analysis, it's all from on-target, which we have gone over. Well, I just want to finish off with registries and whether they're clinical trials. No question, registries which are worldwide are important. They tell us how we are using drugs, whether we're prescribing them appropriately, whether we're following guidelines, whether or not there's very rare side effects that we pick up. But what we have to understand is registries do not override what double-blind randomized controlled trials have shown. And I would recommend for your reading to take a look at 2 recent publications by Professor John Murray in Journal of the American College of Cardiology that he writes, "Only Trials Tell the Truth About Treatment Effects and Randomized Trials versus Common Sense and Clinical Observation." In cardiology, we thought many things were really good from observational studies. We treated PVCs with antiarrhythmics post-MI. CAST trial, we're increasing mortality. We opened up occluded arteries because we thought that was beneficial. The OAK trial proved it's wrong. We went for tight sugar control in the ACCORD trial in elderly diabetics, increased mortality. Inotropes for congestive heart failure trials proved it wasn't good. Increasing HDL, complete revascularization, and probably the most interesting thing is hormone replacement therapy and all the vitamin observational studies, which is probably the healthy patient. So registries are of interest, and I think we should incorporate the data. And I'm going to share with you, my last slide is a registry that I participated in with my colleagues in Korea. And we took a look at post-PCI and what people were discharged after angioplasty. And we took a look at mortality. And as you can see in these patients, if you were given an ACE rather than an ARB, about a 20% reduction in all-cause mortality. That being said, it's of interest and it sort of supports our hypothesis, but you would need a randomized trial to prove that for sure. But what was the most fascinating thing in this is that 60% of people got an ACE inhibitor on discharge, 40% of people got an ARB, despite no guideline anywhere recommending an ARB post-angioplasty. So we did learn something significant from the registry. And sorry for talking so long, and my apologies, and thank you for your attention.
Thank you very much, Dr. Martin, for your very illustrative discussions. And I think one of the most important slides that I really enjoyed was the last one, showing how common sense doesn't work in medicine and cardiology, of course, and in medicine in general, because it seems right to treat PVCs, it seems right to open an artery, but if you go to the evidence, it's different. But my question is, there has been maybe, I think, a misunderstanding that ARBs can increase mortality, which I really doubt much. They don't decrease mortality the same way or the same extent that ACE do, but they are really beneficial drugs. They are not that bad drugs to use. And ACE inhibitors, of course, reduce mortality more, but I don't think that ARBs can really increase mortality or increase the risk to our patients. What's your comment about that?
So there is no question ACEs and ARBs are the same at lowering blood pressure, improving symptomatic heart failure, protecting the kidney, and reducing the stroke. But where they diverge is the impact of myocardial infarction and death. And I think the most important takeaway point isn't that ARBs are evil per se. We have overwhelming data that if you have a high-risk patient, vascular disease or diabetes or somebody of an age, that if you give an ACE inhibitor, you will have a significant risk reduction in MI and death that an ARB will not provide. And one of the things that I don't understand is that you're lowering the blood pressure in the placebo-controlled trials, and you're not getting the mortality reduction. You're not increasing the mortality, but you don't end up doing it. So for uncomplicated hypertension, say a 30-year-old man may not make a difference in what you give him because it's because of the blood pressure. But what that 30-year-old guy wants to do is become a high risk.
Maybe we lost temporarily, Dr. Strauss. Maybe something with the Wi-Fi or the network. Are you with us? Are you with us, Hossein?
I'm with you. Can you not hear me?
Yeah, I can hear you now. Yeah, okay.
Okay. So where did I stop talking?
No,
well, you said they don't.
Your connection, Dr. Adil, هو اللي حصل فيه مشكلة.
My connection? Okay.
Yes, your connection. But I hear you. Everything was good.
Okay. So what I'm saying is a low-risk patient may not matter whether you give a diuretic or a CCB or what. But one thing about being a low-risk patient, you want to become old and become a high-risk patient. So to me, I would always start an ACE inhibitor.
Dr. Strauss, I have seen so many presentations on the comparison between ARBs and ACE inhibitors. I have not seen anything like what you have showed today. You killed the ARBs in my eyes. You did really amazing job in completely making it dead body. Well, I think, Dr. Adil, would you like to...
Yes, there is a question from the audience about the risk of cancer with ACE. What about that? I mean, there's been some doubts about cancer and things.
Yeah, so that was actually published in the British Medical Journal, and we actually wrote a letter, and it was from data from the UK and actually analyzed in Canada. And any difference in the cancer rate and the lung cancer rate was purely related to the era that the drugs were done. So UK had a lot of problems with pollution, with radon and asbestos because of the coal. And that was the increased risk of the cancer, which was shown with the numbers. Because they were separated in time. What we asked the authors to show, well, if you tell me there's an increased risk in cancer, and you might have just detected more because people had a cough or whatever, why don't you share with us the mortality data? And they refused to. They never shared the mortality data. And you and I know if you have more lung cancer, you should be dying. So that one, it was really, it was a sham. And I think it was so sad because people were going to stop the drug because they were afraid of getting cancer. So there's no concern about that whatsoever.
So there is another question about you in Canada. Which is the most used ACE? Is it perindopril, ramipril? What about ARBs? What's the most molecule used?
Well, I think worldwide, ARBs are always used more than ACE inhibitors, and I think it's really comes down to perhaps marketing rather than evidence. In Canada and around the world, most ACE inhibitors are all genericized. In Canada, even perindopril went to generic. And one of the scary things about the generic is if you read the American College of Cardiology guidelines, it says specifically, you never prescribe a generic if there's the brand name available because you know what there is. And as you know, with the ARBs, the whole problem with the different contaminants in cancer, and I guarantee it's not just with the ARBs, it's with any generic drug. So when I go and I get my prescriptions, I always insist that give me an unopened bottle and I want the brand name. I think the most important thing from my perspective, and I tell the doctors, is the most important thing is prescribe the ACE over the ARB in the high-risk patients. And also, if you prescribe the ACE inhibitor with the most extensive data, that I think it would be with perindopril. But I think
in Egypt, we have a very peculiar situation in treatment of hypertension, and beta blockers are still number one. Despite all the facts that we have with ACE and ARBs and all the evidence, still the situation is changing, of course. Still, beta blockers. Yeah,
this is because of the economical reasons.
Yeah,
when you deal, if you look at the economical class that would be able to afford the other the ARBs or ACE, it will be ARB and ACE. But I think, as you say, bisoprolol is not very expensive, and the blood pressure control is better than nothing. So beta blockers are still very common in Egypt.
So, are you with the European perspective that any drug, if there are no compelling indication, any drug that can lower blood pressure is from beta blockers, ACE or ARBs, diuretic, calcium channel blocker, can do the job? What do you think about that?
Yeah, so when it comes to, I think the recommendations now, most of the time is to start a RAS inhibitor and go with a diuretic or a long-acting dihydropyridine. And in my practice, that's probably the vast majority. Where I differ is if they're heart failure or if they're ischemia, I go beta blockers. My fourth drug is always an aldosterone inhibitor. It's truly the most powerful drug in people. I think the biggest thing is that we get people on the medication and we follow them and we give them combination pills, whether it's double pills, triple pills, and that we need to be very, very aggressive with it.
Dr. Strauss.
There's another question. I'm sorry, there's another question about kidney protection, ACE or ARBs in type 2 diabetes.
Yeah, so there's no question. ACE inhibitors were tested in type 1 diabetics, ARBs in type 2 diabetics. But if you biopsy a type 1 and a type 2 diabetic with proteinuria, there is no difference. So they're equally effective. And I think most nephrologists will tell you the power of an ACE and an ARB is really only when you have microalbuminuria or proteinuria. Those are the people who get the most benefit. But either one, I think, have the same renal effect.
I need to ask a question, Fred. Yeah. Thank you, Martin. The presentation was very convincing and very good. My question to you is that most of these studies, if not all, were done in an era where statins were not as important as they are today. So if you look at these patients, statins might not be covering all of these patients. And as you know, when you use statins, risk becomes much, much lower, especially for coronary disease, which is the key for use of ACE inhibitors. Do you think of these comparative studies are done in this day where more than 90% of patients will be on high-intensity statins? If they need to be on, the results will be the same.
Yeah, so that's a great question. We don't know the answer, but what I can tell you is we have certain add-on drugs now for example, in the best treated patients in the world. For example, icosapent, where you add on the new fish oil in people who are maximally treated. DAPA, CKD, and different things like that. You're adding on another drug. But it seems like when we add on another drug on top, there is still so much residual risk that there's a benefit because each of the drugs work on a completely different modality. And that's a classic question of our patient when they say, you have me on 5 pills. And we say, oh, if we had a 6th, you would want to be on that one too, So.
Very good. Okay.
Sam, can you move ahead?
Yes, I think we had a very good start for this symposium, and now we will move to the second part of our very interesting symposium. Professor Krzysztof Nekerowicz. I hope my expression of your name is correct. I will be talking about from dual to triple therapy. What is new? Professor Nekerowicz is professor in Department of Hypertension and Diabetology, Medical University of Gdańsk, Poland.
Okay, so good evening, everyone. The pronunciation was perfect. It is a very difficult last name and first name, but you did a really great job. So thank you very much for the invitation. It's a pleasure to join you online. I hope one day I will have a chance to visit Egypt again. I live in Gdańsk in Poland. So this is Central Europe. We are located at the Baltic Sea. I live in Gdańsk. This is a very, very old city, almost 1,000 years old. Hanseatic city, similar to Amsterdam. 9 years ago, we had the privilege to organize the European Championship in soccer. For many years, we couldn't qualify, so we decided to organize, because if you organize, you do not have to qualify. Anyway, we lost quite early during the tournament. I'm talking about the soccer because, of course, I'm aware that you have your own great hero known all over the world. We have our Robert Lewandowski. He is also a great player, and we hope that next year, during the next European Championship, he will lead the team, and maybe finally we would win the European title. So I will talk about double and triple combinations, specifically focusing on the need for triple combination, but somehow following the earlier discussion and the presentation of Professor Strauss, I think I would stress that we should really try to stress the progress we made. And if you would compare the situation right now with the situation in the 70s, when there were still many cases of malignant hypertension, people dying because of uncontrolled, really very high blood pressure. Rezapine, with many side effects, was a very popular drug. First diuretics were coming to the market. First randomized clinical trials were initiated, and virtually there were no guidelines. And right now, in the year 2020, in Poland, we see very rarely malignant hypertension. It's almost non-existing. We have very well-tolerated treatment with several classes of drugs, with landmark clinical trials. And I think we are very lucky in cardiovascular medicine that our guidelines are based on clinical trials, lovely discussed by Professor Strauss, showing us how much we can learn from those randomized clinical trials, how this might drive our clinical decisions. In Europe, we, of course, somehow try to focus on the European guidelines, the guidelines of the European Society of Cardiology and the European Society of Hypertension. I had the privilege to contribute to this document, and I know that this document was really widely accepted all over the world. In many countries, many national societies, if they prepare the document, they rely on the document of the European societies. So if you talk a little bit broader about hypertension management, the recipe for success is relatively straightforward. We need appropriate treatment, and there's no doubt at the moment this should be a combination therapy. This should be single pill combination because it's much easier for your patient. We need an adherent patient, and this is, I think, a major challenge. We know that despite excellent drugs, despite the clinical trials, despite the guidelines, many of our patients are not adherent. So I think we should be proactive. We should be inertia-free. This is, I think, a very important point. But I think we should also motivate our patients, because if you are able to motivate, if you are motivating our patients, they are much more likely to be adherent. So let's talk a little bit about the difference between 2018 and 2013 guidelines. So the 2013 guidelines, they said, go below 140, but how much below? Many people ask, 139 would be enough, or maybe 130, or maybe 120, or maybe even lower, because 110 is below 140. The new guidelines, they're much more specific. They say, first of all, everyone should have blood pressure below 140, but we have really very strong evidence gathered during the last years that it's much, much better in terms of cardiovascular risk to have blood pressure of 130 than 140. So this is the true new target. But in people who are younger than 65, the guidelines say, if you achieve 130, go lower, because we have the evidence in those people that it should be lower than 130, not lower than 120, but the optimal range for those people will be between 120 and 130. So we have lower target blood pressure, and to achieve lower target blood pressure, we need a new strategy. And three most important points in the new guidelines, which completely changed the previous recommendations, was the single pill combination treatment strategy to improve blood pressure control. Is the must. This is the current standard. It's not the future. It's not an option in management. This is the standard. We should prefer use of two-drug combination therapy for even initial treatment for vast majority of our patients. Single pill, so not giving two drugs separately, but in one tablet, is a preferred choice. And indeed, the guidelines simplified the algorithm, saying that dual combination, this is the first step. Why the guidelines stress the role of single pill combination? Because we really try to understand the issue of non-adherence. This is a very important study published 3 years ago, coming from the registries, from the database in the Czech Republic and in the UK, trying to see what is the risk of non-adherence according to the number of tablets. And you can see if you go to 5, 6 tablets a day, or even 4, more than 40% of your patients are at least partially non-adherent. But this situation is completely different. If you have a patient taking 1 or 2 tablets, then the risk of non-adherence is really much lower than 20%. So the bottom line, the main message from this paper is that the patients, they do prefer to take 1 pill a day. So this is the reason that the algorithm made it very, very clear for the initial therapy. You should consider monotherapy in very selected groups of patients. So only those with grade 1 low risk. If the blood pressure is only very mildly elevated, I would say maybe systolic blood pressure of 145 might be enough for monotherapy, but 150, you need combination therapy. And then older patients, especially very elderly and those who are fragile, then monotherapy might be the way to go. But for the rest, from the very beginning, start with combination therapy, with dual combination, with one pill, and combining in most of the patients ACE or ARB with a calcium channel blocker or with a diuretic. But step number 2, if the step number 1 was not sufficient, then go to a triple combination, and there's just one way to go: drug blocking renin-angiotensin system plus calcium channel blocker plus diuretic. If this is not enough, rule out secondary hypertension, rule out white coat effect. And if you rule out those conditions, then, as Professor Strauss mentioned, as Martin mentioned, go to anti-aldosterone drugs, and the strongest evidence we have is for spironolactone. Of course, there is a place for beta blockers, specifically when you have heart failure, post-MI, coronary artery disease, atrial fibrillation. Then actually, beta blocker will be the drug of the first choice, combined with drug blocking renin-angiotensin aldosterone system. And I'm saying we because I know that Marty would agree, in such condition, we would prefer a combination of ACE inhibitor with a beta blocker, because this would be the best option for those patients with underlying overt cardiovascular disease. So why the guidelines so actively encourage starting treatment with combination therapy? Because you have better and faster blood pressure control. A very important component when you initiate the treatment, if the patient is coming for the second visit, if the blood pressure doesn't change at all, then from the very beginning, you might have a problem with the adherence. Because if a patient is compliant, virtually all of your patients will respond, and you have much less variability in terms of blood pressure lowering effect of single pill combination. It is safe and well tolerated, much better than monotherapy in a high dose. You improve the adherence because you have fewer pills, and in 2 simple treatment steps. And more than 80% might be controlled with 1 tablet. And I think it's an incredible achievement in the history of hypertension management. The question, when, rather in the morning or in the evening, or does it make any difference when you give a pill? There is a difference. This is a very important meta-analysis trying to see what is the probability of non-adherence according to time of the day. And you can see when you give at the variable times, morning, evening, and an afternoon, there is the highest risk of non-adherence. It is lower, but still quite high if you give it in the evening, and the lowest risk of non-adherence. The best, in other ways, the best way to go would be to give this tablet in the morning. So in summary, if you would compare the strategy in 2013 and the newest guidelines, the initial combination therapy in stage 1 was not recommended at all in 2013. It is now recommended with the highest class of recommendation. The initial combination therapy is stage 2 and 3. It was recommended in 2013, but with relatively weak class, with 2B, now the strongest class of recommendation. The preferential use of single pill combination, it was recommended, but once again, with a weak class, 2B in 2013, now the strongest class of recommendation. And you might ask a question, how many patients would require a single pill combination? And year 2013, maybe around 40%. Now I would estimate more than 80%. So only those who are fragile, those who are very old, and those with very mild elevation blood pressure will be candidates for monotherapy. All the rest would be the candidates for a single pill combination. So in general, the single pill combination in hypertension management meets the challenge. We know that monotherapy is not the way to go. It takes into account the human factor. The patients do prefer to take 1 pill in the morning. It minimizes the risk of our failure. If we prescribe such drug, the patient is likely to achieve blood pressure improvement or even control. And then, of course, it improves your relationship with the patient. You give a drug which works, and then the long-term compliance is much, much easier. And as I said, it's not the future. It's not an option for hypertension management. This is the current standard, completely replacing previous strategy in hypertension management. So let's go to the triple combination. And I know this combination is coming to your market. It was with us already for several years. So you might ask a question, why we need a triple combination in 1 tablet? Why we should consider it earlier in more patients? Why should it be more frequently used? And how? What would be the best way to go? Why this new triple combination offers an advantage over any other potential combination therapy in hypertension management? So why we need it? The answer is very simple. The blood pressure control is not satisfactory. This is a very important Euro-Aspire trial. We have data every few years in the best hospitals in Europe. And the Euro-Aspire 4 was published already 7 years ago, and Euro-Aspire 5 is from 2 years ago. And you can see that in Euro-Aspire 4, 50% of the patients discharged from the hospital, they had uncontrolled blood pressure, and nothing changed. The situation didn't improve during the period between the Euro-Aspire 4 and 5. Why earlier? I mentioned in the previous guidelines, triple combination therapy was really at the end of the algorithm. Now this is already a second step in hypertension management. What's another argument to consider it in more patients more frequently? Because we should get moving fast. The sooner you get the blood pressure control, the greater reduction of cardiovascular risk. And the guidelines say it will be the best way will be to get the blood pressure control in 3 months. And you could do it with triple combination. We have several studies that the old approach, the stepped care strategy, you start with one drug, you go to the maximum dose, then you get another drug. This is not the way to go. With a combination therapy, you get the blood pressure control much, much faster. Why more frequently? The cardiovascular regulation is very, very complex, and I'm just showing the computer model of Arthur Guyton's theory, showing the complexity of cardiovascular system. It would be very naive that if you block one mechanism, you would achieve blood pressure control. Furthermore, those people who are on 1 or 2 drugs are most likely to be uncontrolled, and the uncontrolled hypertension occurs frequently in those patients. So there's a space for improvement in this particular setting. How many patients will require triple combination? If you go to the guidelines from 2009, more than a decade ago, the guidelines say between 15 and 20%. In the year 2013, the guidelines said 3 or more drugs are needed in 25 or 30% of the patients. In the newest guidelines, we didn't say specifically how many patients will require this, but we have lower target blood pressure, especially in younger people. So probably the number of patients is higher than that. How can we estimate the number of the patients which will require drug number 3? The ASCO trial. We talk a lot about the ASCO trial. As we know, the combination of amlodipine and perindopril was the first step in those patients. But the step number 3 was doxazosine. So how many patients require drug number 3 in the ASCO trial? You might be surprised, more than 60% needed a third drug to improve blood pressure control. And it's a lot of space for improvement. In this Euro-Aspire study that I showed you, only 40% of the patients were on 3 drugs. Despite poor blood pressure control, the physicians somehow didn't intensify the treatment. How? The answer is very, very simple. We have the algorithm, and I think we should really take into consideration this, what was already mentioned by Professor Strauss, that the old approach, the previous approach, blood pressure reduction, then we thought lower brachial blood pressure measured in the office. Now the new standard novel approach is, of course, it is important to lower brachial blood pressure measured in the office, but we also would like to lower central blood pressure. We would like to provide 24-hour blood pressure control, and we need long-lasting drugs like perindopril. We would like to reduce also blood pressure variability. And finally, last but not least, we would like to ameliorate mechanisms underlying cardiovascular risk, and renin-angiotensin system underlies development and progression of hypertension and cardiovascular complications. So what would be the ideal core component of such a single combination? And potentially you might consider a single triple combination therapy based on ARB or ACE inhibitor, as you know. But the ideal core component should be useful in various clinical conditions, not only hypertension itself. It should be useful in different age groups. It should be available in combination with several drugs, ideally with a diuretic, with a calcium channel blocker, maybe with a beta blocker. And it should be available in double and triple combinations. So you start with double combinations, not enough. Then you go to a triple combination based on the same core component. You add one drug inside the same tablet. From the patient perspective, nothing changes. He was taking one pill, he's continuing to take one pill, but which is more powerful. And most importantly, it should be supported by clinical trials, by evidence-based medicine. And as mentioned by Marty, we have the evidence in terms of mortality. Such evidence is existing only for the ACE inhibitors, is limited to trials based on perindopril, and perindopril is the best studied ACE inhibitor, and probably one of the best cardiovascular drugs studied in the last decades, showing the benefits in hypertension, in diabetes, in coronary heart disease, post-stroke patients. So one might say that perindopril is also the king of the single pill combinations. We have for already several years in combination with amlodipine, and we know we could talk about molecular synergy because of the ACE working mostly on endothelium, providing the improvement of the endothelial function, calcium channel blockers working mostly on the resistance of the vessels. We have the potential clinical synergy, as already discussed by Professor Strauss. The ACE inhibitors provide the benefit for coronary arteries beyond blood pressure reduction, while the calcium channel blocker might provide such benefit for stroke. So you get the benefit of two classes for prevention of the most important endpoints in cardiovascular disease patients. So how to combine ACE inhibitor, perindopril with famotidine would be the best choice. And as you know, this new triple combination coming to your market is based on indapamide, and indapamide might provide the advantage in terms of blood pressure reduction over hydrochlorothiazide. It might provide the benefit in terms of the reduction of cardiovascular events compared to hydrochlorothiazide. And finally, we have the trials. All the trials, the new trials, showing the benefit were based on indapamide. Such trials, they do not exist for hydrochlorothiazide. This is the new review by Michel Bournier, George Beckwith, and Brian Williams, so authorities from different countries, showing indeed that also when you talk about metabolism, when you talk about lipids, if you talk about glucose, the thiazide-like diuretics, chlorothalidone and indapamide, provide the benefit over hydrochlorothiazide. So the final slide from the guidelines I would like to show are the guidelines of the International Society of Hypertension, published just 3 months ago. At first glance, they look quite similar to the European guidelines. Indeed, they do prefer double combination. They do prefer triple combination. So triple combination is the very important step in the management of hypertension. But if you talk about diuretics, the guidelines of the International Society of Hypertension, they stress they prefer thiazide-like diuretics like indapamide. So what you get with this new pill, you have perindopril, amlodipine, indapamide. You have a perindopril, not an ARB, giving all the advantages summarized by Professor Strauss from ACE inhibitors. You have indapamide, so thiazide-like diuretic, better than hydrochlorothiazide, and several trials surrounding this, showing the evidence we have for the trials. When this new combination came to Poland, some physicians were a little bit scared. Maybe it's too powerful, 3 drugs for a patient. But we should not forget the pharmacokinetics of the combination. Each of the substances have slightly different combination. So for indapamide, you get the maximum effect coming first, about 1 hour. The whole effect covers mostly daytime. For perindopril, it's a long-lasting drug. As I said, it covers exactly 24 hours, but the maximum effect would come within 3 to 6 hours. And amlodipine, which works for more than 24 hours, the maximum effect comes between the 6th and the 12th hour. So those pharmacokinetic profiles, they overlap. There's no moment of the accumulation of the effect, and especially in a steady state, if the patient is taking drug for several days, you get kind of smoothing effect. We have the evidence coming from the trials, from the advanced trial mentioned by Professor Strauss, with then we have the evidence showing for the calcium channel blocker. So you might ask the question, what would I get the benefit if I switch from double combination, triple combination? This is exactly what you get. Patient uncontrolled on 2 drugs, you switch to the triple combination, 1 tablet, and you improve blood pressure control quite dramatically. What is the risk? What I showed you the enormous benefit. The risk is very, very, very small. In the advanced CCB trial, almost no increase in discontinuation due to hypertension in triple combination. Another trial, the Pioneer trial, showing that you achieve enormous improvement in blood pressure control. You can see 80% of people controlled with ABPM, but adverse effects were really, really very low. So this is my last slide, the summary. I would say this new triple combination based on perindopril, amlodipine, dapamide, this is the second step in hypertension management. Many people who are not controlled on double combination will require this triple combination. It will facilitate blood pressure control in difficult to manage hypertension. And many of our patients are difficult to manage. It is consistent with patients' expectation because you have 1 tablet given in the morning. And finally, it provides optimal cardiovascular protection. Thank you very much for your attention.
Thank you very much, Professor Markowitz. I think you have done a great job showing that triple therapy with the proper choice can be a very important treatment step for most hypertensive patients. Let me ask you, do you think there is an evidence for the triple combination that would include ARB in the combination as compared to ACE inhibitor with amlodipine and plus minus hydrochlorothiazide? We have.
I think it's a very, very important question indeed, because we talk a lot about ARBs and the meta-analysis presented by Professor Strauss, but we do not have even any study looking for a dual combination. So we do not have a study showing that ARBs with calcium channel blocker will provide the benefit. We have such evidence for perindopril with amlodipine, but such evidence is not existing for hard endpoints for the ARBs. So I think it's another advantage of this combination.
Excellent. We have Professor Subhi. Professor Subhi is one of the eminent professors in Egypt. He's the chairman of cardiology at Alexandria University. He's an ex-chairman, and he's ex-chairman of the Egyptian Society of Cardiology, and currently he's leading cardiology in a very big, eminent professor. I'd like Professor Subhi to give his remarks.
Thank you, Dr. Hussam, Dr. Adel. Thank you very much. I'm sorry, I was having 1 hour with the ACC. It's a webinar with the NCD Academy, so I have to be there. So I left them for this hour. So I heard your lecture. In the last few weeks, Servier is doing an advisory board regarding the triple therapy. We have triple drugs in the market now. We have 2 ARBs, and one is, you said, olmesartan triple, valsartan triple, perindopril triple. Do you think that the perindopril triple is important than the others because they have already trials and there is no extrapolation? Or it depends on the trough to peak ratio, the time till the end, 24 hours? How to differentiate between the triple? Question is, which patient profile you shift to triple? I mean, if you are already on ARBs with combination, this dual therapy, a combo, and then you shift to triple, are you going to shift to triple, the ARBs itself, and then you go to the ACE triple? How can you manage this patient?
So I think you should take into consideration the overall risk of your patient. And I think just following the lecture of Professor Strauss, if this is a young patient already on an ARB with maybe a calcium channel blocker, and you have an option to go to a triple combination, maybe you might do it. But if anyone will have a higher risk, first of all, I would rather, following the suggestion of Professor Strauss, I would start with ACE inhibitor, this patient, also for the dual combination. And this is not enough, I would go to a triple combination. In my country, in Poland, we have really many patients who are high or very high cardiovascular risk for various reasons. And I think it's a bit in contrast to the general perception of sometimes of the GPs who believe that, only a small proportion of my patients are really high or very high risk. Only referral centers, they do see very high risk patients. But it's not true if you take into consideration target organ damage, the impairment of the large and small arteries, if you take into account the lipids and so on. Actually, many of your patients are high risk. So in our countries, overall, there are more patients who are on ACE inhibitors than the ARBs. So I think this is my answer. Take into consideration the overall risk of your patient. For sure, there is an advantage in everyone with underlying coronary artery disease. The guidelines are very clear. ACE is preferred over ARB. In everyone with heart failure, and I think in everyone with diabetes, I think this is no discussion that ACE will be better. In the others, then you should consider individual approach.
Let me ask you a question. If you have a patient who was receiving amlodipine 10 milligram, perindopril 10 milligram, and his blood pressure is uncontrolled, recently became uncontrolled, would you give him a dopamine combination or a combination of 10, 10, and 2.5, or you would give him 5, 5, 1.25?
Well, this triple combination is with us already for a few years. We are quite lucky to have this combination with us already for 3 or 4 years. So in general, I think if I start a combination with perindopril and amlodipine, probably we all will agree that in most of our patients, we start with 5 milligrams of perindopril, 5 milligrams of amlodipine. This is the average dose of two drugs. And then I really quite easily would increase the dose of perindopril. So I rather would like to have, especially my high-risk patients, on a high dose of perindopril. And if 10 milligrams of perindopril and 5 milligrams of amlodipine is not sufficient, probably if I would talk about my patients, then I would go to a triple combination rather earlier than going to a very high dose of a double combination in our case. Because we had such option already for a few years. So then I would go 10 milligrams of perindopril, then I would go 5 milligrams of amlodipine, and then indapamide. But probably for those patients in your country, if you have somebody on a high dose of perindopril, amlodipine, and this new combination is coming to the market, it depends on the level of blood pressure. If you are far away from the control of blood pressure, then I would go immediately to 10, 10, and indapamide. If you are slightly above the limits, and maybe your patient is a bit older, maybe you are a little bit more concerned, then maybe I would decrease the dose of amlodipine and add indapamide as the third drug. If this is not enough, then later on go to a higher dose of triple combination. This is my suggestion, but we are in a little bit lucky situation because we had this combination already for several years.
Yeah, we have it now for almost a month, and I think it's a very powerful combination. I have seen very marvelous results, early results with this, and I think I would definitely be very satisfied with this triple therapy at 5, 1.25, and then if I will give the higher dose, I think most patients will be controlled on this dose.
I have two questions, please. The first thing, there is a common question to you about when there are, of course, we know the guidelines say dual therapy to start with, better single pill. Is there a situation, which we are frequently asked this question, is there a situation where you can start the triple therapy from the very beginning? This is one thing. And if you don't have good control, what would you be after triple therapy, the fourth step of treatment? Mineral receptor antagonist or beta blocker? What do you think?
So starting with the question about triple combination from the very beginning of therapy, the guidance make it clear probably this is not the right time. We do not have the evidence, and probably we do not want to achieve blood pressure control in days or just weeks, and probably it is too strong for many patients. So I do not start triple combination in my patients. If the blood pressure is really even a very, very high, even in unblunted blood pressure monitoring, I would rather start with a double combination, rather higher doses, screen the patients for unblunted blood pressure monitoring and see him rather soon, and then go to triple combination, because probably triple combination might be too much from the very, very beginning. So rather not. Maybe in the future we will see how the things develop. Maybe we would consider starting triple combination, but probably with the lower doses than currently recommended. But the evidence is not sufficient enough to recommend triple combination at the initial phase in any of the patients.
But you have trials saying that there is no difference whether you use it in grade 2, grade 3, grade 4 hypertension. Even it's a minimal reduction in grade 2 and severe reduction in grade 4. So I think it can be used in all grades of hypertension.
Grade 2, grade 3, I do agree. But for grade 1, there are no really randomized.
Yeah. I'm not speaking about grade 1. Yes.
No. So grade 2, grade 3, you might consider, but I would be careful, really, in those patients. Really start with double and then go really in the next step to triple.
Okay. You have 5 trials of prendopril in Advance, Ascot, Europa, Progress, Hybrid. Okay, I agree about this. And this is variable according to diabetic, elderly, coronary, cerebral. And you have with prendopril the blood pressure variability in the Ascot and trough to peak ratio. So what is the patients? I mean, in all these patients, can you advise that because already you have trials and you have evidence of continuation within 24 hours, this triple combination is beneficial in these 5 categories?
Right now, we have the evidence for diabetes. Unfortunately, we do not have direct randomized clinical trials in other conditions. So it would be better to have those trials, but based a little bit on common sense and so on. I think we can extrapolate and use this also in other conditions.
So you think that the clue is the indapamide? So I mean, if you prove this, that indapamide is the key part of the triple, it's completely different to other 2 ARBs. The other 2 ARBs with calcium blockers and hydrochlorothiazide, but this is the difference here. Is indapamide?
I think indapamide makes a difference, and we have the evidence. Unfortunately, there are no head-to-head randomized clinical trials comparing indapamide with hydrochlorothiazide. So it would be better to have such trials, but right now I'm just following the evidence we have. So and the evidence we have is just only for indapamide. And then coming to the previous question about what should be drug number 4 in these conditions. So I think we have the pathway trial. All of you are familiar with the trial, suggesting that the anti-aldosterone drug would be the drug of choice, and probably this is the way to go. On the other hand, we should not forget that in many patients we should consider intensification of a diuretic treatment. Sometimes this is the reason you should intensify diuretic treatment. In some of the patients with really faster heart rate, and there are no randomized clinical trials, but probably just our experience. So when I see a patient with not responding to 3 drugs, but with faster heart rate, maybe a beta blocker would help. But in general, the guidelines, they do recommend anti-aldosterone drugs as the next line after the triple combination.
Dr. Strauss said that ARBs are dominating the market in spite of the very strong evidence that he showed for the ACE inhibitors. Do you think in your country, and he said that marketing has the reason probably behind this difference in favor of the ARBs, do you think the combinations of ARBs with calcium channel blockers in Poland are more common than ACE inhibitors with amlodipine? Because in Egypt, it's It's the same like for ARBs and ACE inhibitors for combination as well. What's the situation in Poland?
I thought there was the question for Professor Strauss. So
I want to answer before Professor Strauss.
I can answer. So in Poland, the combination of ACE and a calcium channel blocker is more popular than the combination of ARB and calcium channel blocker in Poland.
Okay, good. Dr. Strauss, is the combination in Canada and North America for ARBs and calcium channel blocker are more popular than ACE and calcium channel blocker?
So I can speak for Canada, can't for the US. So what I can say is the ARB diuretics they were more popular because in Canada, the first thing that came out with the ACE inhibitors. And then we learned quickly that when you add a diuretic to an ACE inhibitor, it's great. So when the ARBs came out onto the market, they came out simply as an ARB or an ARB with a diuretic. So they dominated the market because they were sort of the first ones out. When it came to the calcium channel blockers, it was actually only the ACE inhibitor companies, specifically Perindopril, that marketed it with a calcium channel blocker with amlodipine. I don't think any of the ARBs in Canada are doing with a dihydropyridine calcium channel blocker, as far as I know. So it's interesting how every country does it a little different.
I'm talking about valsartan with amlodipine in your country.
Yes. Yeah, we don't, as far as I know, we don't have valsartan mixed with amlodipine, as far as I know. But I don't prescribe the ARB, so I could be missing it. But as far as I recall, there is not the combination in Canada.
In Egypt, to just have an advisory board last week with the young generations and the older generation that they recommend the ARBs, as Hossam said, Dr. Professor Hossam, because of cough. But there is claim coming to me that, just paper, I read it about this decrease of cough or combination therapy with perindopril calcium blocker and dopamine because of decreasing prostaglandin and the central effects. So this cough is decreased. So do you think that if you have a combination which decrease cough, is it effective to start with? Because all of the Egyptians market afraid of cough. That's why they start with ARBs. This is the main reason, not mortality reduction or morbidity or any end organ protection. They believe in cough. So if you have something which decrease cough, which is published in this paper, decrease cough, central.
Yeah. So I don't know whether anything would decrease the risk of cough, but what I would tell people is that the studies show 3 to 5% of people can't tolerate it with a cough. Some people will say, no, 50% of the people can't tolerate an ACE inhibitor. So I tell those physicians two things. So even if 50% of your patients will cough on an ACE inhibitor, are you going to deny the other 50% a life-saving drug because they may have a cough? So that's one thing I say. The other thing is some physicians in some countries say, well, if my patient gets a cough, my patient will go to another doctor and they'll tell them your doctor is not too bright because he picks a drug like that. And when I prescribe the drug, I tell patients, and we're talking about high risk, diabetic, vascular disease over the age of 50, very simply. I'm going to give you a drug. It's going to make you live longer, lower your blood pressure. 5% chance you're going to cough. There's another newer drug that I can prescribe for you, won't cause a cough, but unfortunately, it won't reduce your risk of heart attack and death. And I care about you. I want you to live longer. And if you have any problems, you call my secretary, Grace, and she'll fax in another prescription. So what you've told the patient is a few things. Number one, you're a smart cookie. Number two, you care about them. And number three, what you're going to do, and they're not going to call you. And that's the most important thing. The last thing we want to do is speak to the patient if there's a problem. But we already have a system set up. And then the next time I get the chart on the patient, when they come, oh, you had a cough and it was switched. So I don't think cough is a problem. And I don't really think anything will prevent the cough. But the most common reason people cough, period, postnasal drip, GERD, viral illness, or whatever. So if they do cough, you stop it, try something else, and reintroduce it later. That's my approach.
Okay, another question. Do you think that we are in the era not only blood pressure reduction, we have to attack the blood pressure variability and the central aortic pressure in the management of hypertensive patients? So we are looking for a drug which can affect these two items, and this can be detected by machines or ambulatory pressure machine for central aortic pressure, and then to change the guidelines, because already I think that blood, if one of the theories
Martin has covered this. Professor Strauss has covered this in his lecture.
I didn't touch the first lecture, so okay.
Yeah, he did a wonderful presentation about this, and I think he made the point very clear that ARBs are definitely not to be tried first. There has to be a very good chance for ACE inhibitors, and those who are not responding or having cough, then maybe we can try something else.
Yeah, but see, they did not. The ARBs will not decrease central aortic pressure while improving blood pressure variability. Yeah, I think this.
So I think that's an interesting question, and Christophe may know more of the basic science and whether amlodipine is better to decrease the intra-aortic pressure or an ACE or an ARB. In a way, is sort of it's interesting but immaterial. We have so much room to treat people just based on what we know today with getting the targets, getting the compliance, physician inertia, that I think we should be focusing on. All of that will do the most for our patients, I think.
Okay, thank you.
Dr. Adil, would you close?
Okay, thank you very much for a wonderful webinar with too much information, and we enjoyed both talks of Dr. Martin and Dr. Nakirich. And I would like to thank my co-chairman, Dr. Hussam Andil, and our co-chairman, Professor Mohammed Sobhi also, and thank Servier for arranging such a wonderful webinar. And I hope we'll see both of you here in Cairo, maybe next year. And thank you all for attending this important webinar, and we will meet again in next webinar. Thank you all.
Good. Thank you very much.
Bye-bye. Thank you.